So some of the topics that we're going to be talking about are really at the joint capsule insertions and origins on both the medial and the lateral aspect. So this picture I think is important to note kind of where these are attaching, and at the very end I'll have what our protocol is. But essentially, what we'll do is have the 5 millimeter pad centered almost. It depends on the size of the dog. So say you have like a pity sized dog, that pad is going to be almost the width from the fibula to the patella. And so I'll have like my thumb and my middle finger on those two landmarks, and then I put the pad in between the two, and that way I'm centered, and then I'm kind of rocking that probe back and forth over that, and that's kind of getting the origin of the medial and the lateral side, and then I'll do that both medially and laterally. And then on the distal aspect, similarly, for the lateral aspect, I use the 20 millimeter pad, and then I'm feeling the fibular head and the patellar ligament insertion onto the proximal tibial tuberosity. So I'll put my fingers there and have the probe centered between the two and rocking back and forth. So if an osteotomy was performed, then that's going to be hitting that osteotomy for almost all of the types of osteotomies that exist. But we'll talk about that too. But basically, that's also going to help with that joint capsule at the origin insertion there. And then medially, if you have a plate there, you want to skip over the plate. You don't want to be going right over the plate, partially due to vibrations, which some of the vibration concerns have to some degree been alleviated with the advent of locking plates. But back when everybody was using dynamic compression plates, then the vibrations could cause screws to back out of these plates. Not only that, it's reflecting your sound waves back out at you, so it's not getting to the osteotomy. So you may say you're doing 1,000 pulses. If you're doing 500 of those over the plate, you're really only giving 500 to the osteotomy itself, because anything that's hitting the plate is reflecting out. The concern of the screw loosening, I wouldn't be too concerned about screw loosening anymore with the advent of locking plates, but it's still not smart to go over that. And then if you didn't do an osteotomy, then you have the insertion of the joint capsule there medially. And so you still have that aspect where you're trying to improve all the origin insertion of joint capsule so that you improve the range of motion, because they have shown in humans and in dogs that the range of motion is directly tied to weight bearing as well. So if you can improve range of motion according to the goniometry measurements, then you're going to improve how these animals are using their legs. Okay, so here's a wide variety of stifle surgeries that you may encounter. And excuse me, I think for those of you that are not doing the surgeries in your hospital, it's really important for you to get the x-rays. And I actually tell my staff that for all of our cases, they better be looking at the x-rays as well for every case, because sometimes depending upon that dog's anatomy, I slightly shift how I have the plate oriented and things. And so it's really important that you guys know where these osteotomies are if you're doing an osteotomy. So in the top left, you have the tibial tuberosity advancement, or TTA. Sometimes you might be seeing these cases where you're like, what's going on? There's no cage in this case. That's probably because they used a bioabsorbable cage, if that's the case. So don't fret, that's normal as well. But in these cases, you're trying to go right over where the osteotomy is, and you don't want to hit right at the cage as well. So a lot of these, you're going to be going, when you go to the lateral aspect, you're going to be hovering more cranially when you go with your pulses. So you want to follow down that vertical cut for a TTA, as opposed to like right next to it, you have a to the right there, you have a CBLO, or a Cora-based leveling osteotomy. So ultimately, that's leveling out the plateau, similar to what a TPLO does, or a cranial closing wedge. But that is a little bit more distal for the cranial aspect than what a TPLO is. And you also then have that headless compression screw. So you want to avoid these things. So by seeing what the X-ray looks like, that's going to guide you as to where you utilize your probe. And then in the bottom left, we have a TPLO there. And then on the just to the right of that TPLO is an AP view of a TPLO. So if you can see between the proximal 3 screws and the distal 3 screws, there's a really thin line there. My mouse is not showing up to be able to show you that, but there's a really thin line there of where the osteotomy is. And then just to the right of that is a TPLO with a distal femoral ostectomy for a dog that had combined patella luxation and cranial cruciate ligament repair. So in those distal femoral ostectomies, you're taking out a lateral wedge and closing that down, but the plate is going to be lateral. So in this case, I kind of go slightly above where I'm trying to go for the joint capsule insertion. And so I will still do the joint capsule insertion, but then when I go just above that, that's where I'm going to be hitting that osteotomy. And I'll treat that osteotomy site the same way that I do a TPLO site. But it's important to have those x-rays so that you can guide where does your probe need to aim. So on one like this, where I only have a lateral plate, and then I'll center on the bone, and then I'll slightly cheat just a little bit caudal. And I'm like in equine x-rays, they taught us to really be good about naming them from like this is a caudal to cranial projection, or sometimes you slightly oblique it and you go through the whole long name. So basically, I'm starting lateral and I slide the pad just caudal to where the plate would be, and then I'm angling it, so I'm going to be going from caudal lateral, shooting towards cranial medial with about 1,000 pulses there. And then I feel the plate again and I rock it cranially, and then I'm shooting from cranial lateral to caudal medial with that. And so you're trying to get kind of bioblique pulses through the osteotomy lines. But this is basically just important to show you, look at what procedure was actually done, and then where did that surgeon place those implants, so that then when you're going through and providing the extra therapy to make the surgery look good and heal well, then the shockwaves need to be guided appropriately to get the most effect out of it. Okay, so for those of you that have the PiezoWave and the manual for it, this chart should look familiar for you. So you can go through a very wide range of energy that you can put into these tissues. And that's one of the things I like about it, is the versatility of it, as well as being ultra focused with the different pads that you can add on to it. But most of what I'm going to be talking about is going to be at setting level 9, which is at the 0.15 millijoules per millimeter squared. Okay, so what do we do?
So there's 2 lateral sites and 1 cranial site, one kind of right at the TPLO site, and then 1 medial proximal site for the Stifle post-op TPLO, or post-op really any kind of osteotomy such as TTA, CBLO, cranial closing wedge, any of these. So first, for the proximal lateral site, then typically I will feel the patella and then the lateral fibula, And then once I've felt that, so I'm gonna have my hand here, keep the leg extended. So once I feel that, I'm gonna have my thumb and my index finger in between those two sites, or at those two sites. Then for positioning the head, you're gonna have the 5mm head for most dogs. You're gonna have that basically centered between those two fingers, and then you're gonna be rocking back and forth, and this is getting that proximal origin of the joint capsule there between that, and that's gonna help with elasticity of that joint capsule. So you're gonna be rocking back and forth for all of those pulses. Typically I do 1,000 pulses at this site at a setting of 9 for the intensity, which is the 0.154 millijoule per millimeter squared. And then I usually do about a frequency of 8, but the frequency is the part that I usually play with to see how patients react. And then I'll usually go through and get all the ones with the 5mm head done next. So then I'll feel for the patella and the tibial tuberosity here to here, and each dog is going to be a little different for that, but for the tibial tuberosity, you're feeling right at that patellar ligament insertion, and you're going to put the head there right over the patella ligament, and I do 800 pulses right over that patella ligament, and I'm just rocking it back and forth so that I basically hit down to the patella ligament insertion, and then you're going to rock up to right at that patella ligament origin at the base of the patella. So that's going to be 800 pulses there. Same settings at 9 and a frequency typically of 8 for me. And then you're going to slightly externally rotate the leg, and then again with the 5, you're going to feel for the patella and then that medial fibula or medial femoral condyle. You're going to feel that caudal aspect of it, and then same thing that you did laterally, you're going to be basically putting the head right between your fingers there, and then you're going to be arcing back and forth, so that way you get that whole medial origin of that joint capsule. And you're going to be doing 1,000 pulses there with a setting of 9, and then frequency of 8. And then the medial osteotomy site is really what you need the x-rays to be able to show. So at that point, if you're doing a TTA, your cut is going to be more proximal to distal at the tuberosity, versus the TPLO is going to be a radial cut, and a CPLO is a radial cut but basically backwards from a TPLO, and a cranial closing wedge is going to be a linear cut. But even within TPLOs, CPLOs, even within the same surgery, each dog is a little bit different, so you should be able to look off of the x-rays of where the osteotomy was made, that surgeon did it, and then you can angle your head. You don't want to have the head directly at the plate itself because it can cause vibrations and it can reflect back the sound waves. And so you want to be off of the implants. And so like a typical TPLO, I'll feel where that patella ligament insertion is, and then I'm going to go just medial to that. And I can usually, for most dogs, unless it's a really fat dog, then you can usually feel right where that plate is, and then you're gonna sit. You usually have about 1 centimeter or so that you can kind of angle right at you're sitting at the tuberosity between the plate, and then put your finger back here at the fibular head, and you want to aim your probe basically right at your fibular head, and then you're just going to arc that back and forth there, and that's going to get that cranial aspect of that osteotomy for a typical TPLO. And then you'll do 1,000 pulses there along with a setting of 8, and then typically I'll switch heads. For the average dog, I'll switch heads and go over to the 20mm, And so then lateral distal, so I'll feel the tibial tuberosity right where that patellar ligament is inserting, and then feel the fibular head. And I'm going to put that 20 millimeter head right here and arc back and forth. This is getting a couple of things. One, it's getting the distal aspect of the lateral joint capsule inserting, but it's also getting that lateral cortex of the osteotomy site. And so I'll rock back and forth for those 1,000 pulses at a setting of 9, and then a frequency of 8 as well. So really you're getting 1,000 here, 1,000 here, 1,000 medial, 1,000 medial distal, and then right here you're getting 800 right at the patellar ligament. And then it's basically 5 millimeter head for almost all of that, unless you have a really big dog, and then laterally you would be doing the 20 millimeter head. But you use your discretion. If it's a really big dog, then you might have to up your head size for those others to like a 10. It just depends on how big the dog is. But typically that's all that you do for that. And most dogs will tolerate that really well at a setting of 9. Those that don't, usually it's a frequency problem, and you can work up on the frequency. Or if you need to change the intensity, then you can usually go down to about 5 and work your way back up to 9. And then once you get to 9, just make sure you get all the pulses that you're trying to accomplish at that site.